All right, let's jump right in with a rapid clinical review of Henoch-Schönlein purpura, or HSP. This is a really high-yield topic for your board exams and, for sure, a condition you'll encounter in your clinical practice. Let's get started. So first up, we've got to get the fundamentals down pat. What exactly is HSP, and what's the pathophysiology behind it? Mastering this is what makes recognizing the clinical presentation so much easier.
Okay, here's the definition you absolutely need to have locked in your memory. Henoch-Schönlein purpura is an IgA-mediated small vessel vasculitis. Basically, it's an inflammation of the small blood vessels. Every single part of that definition is clinically significant and, believe me, vital for exam purposes.
So let's break that down a bit. The IgA-mediated part is what puts it on the same spectrum as IgA nephropathy, which you might know as Berger's disease. The small vessel vasculitis part, well, that explains the classic purpuric rash. Clinically, the textbook case, the one you'll see in vignettes, involves a child who shows up a week or two after something like an upper respiratory tract infection.
Okay, so we've got the science down, but how does this actually look when a patient walks into your clinic or the emergency department? Let's translate this pathophysiology into the real-world clinical picture.
The presentation is classically defined by what we call a tetrad, 4 key features. You've got a palpable purpuric rash, abdominal pain, polyarthritis, and then the most significant complication, which is renal involvement. This tetrad is absolutely crucial for your differential diagnosis.
So out of those 4, the rash is usually the thing that jumps out at you. It can be pretty striking, but what's the specific thing, the almost pathognomonic sign that you really need to be looking for?
And here's your answer. The key feature is that the purpura, those non-blanching spots from bleeding under the skin, is palpable. You can actually feel it. It's raised. And that's because of the underlying inflammation and the red cells leaking out from that vasculitis. The distribution is also a dead giveaway. It's typically symmetrical over the buttocks and the extensor surfaces of the limbs. All right, let's circle back to the renal involvement because, honestly, this is the part that can cause the most trouble long-term. It can be anything from just microscopic hematuria you pick up on a dipstick all the way to full-blown progressive renal failure. This is that IgA nephropathy component of the disease really showing itself.
Okay, you've nailed the diagnosis. Now what? What's our game plan? Let's talk about the management strategy and what you can tell patients and their families about the prognosis.
Look, for the most part, management here is all about being supportive. The condition is generally self-limiting, so the real focus is on symptomatic relief. Giving some analgesia for the joint pain, and then just being super vigilant about monitoring for any potential kidney complications.
But what about the kidneys? This is a huge point and a classic exam question. Even for the nephropathy, management stays supportive. The evidence for using things like steroids or other immunosuppressants is pretty inconsistent, so it's just not considered routine practice.
So what does monitoring actually look like? Well, it's pretty simple, but you have to be consistent. We're talking regular blood pressure checks to screen for any hypertension from kidney injury, and serial urinalysis, looking for hematuria and proteinuria. And this isn't a one-and-done thing. This monitoring can go on for months after the initial illness.
Now, the good news here, and it is good news, is that the prognosis is generally excellent. In the vast majority of cases, especially in kids who don't develop any significant renal issues, HSP just resolves completely on its own, with no long-term problems.
But there's a catch, and this is a really important thing to tell families: the risk of relapse. Around a third of patients will actually experience another episode. It's so important to communicate this, so families know what to look out for and when to come back for medical attention.
Okay, time to bring it all home. Let's do a final, super focused summary. Think of this as your go-to slide for last-minute revision.
Right, here we go. High-yield facts only. Pathology, IgA-mediated small vessel vasculitis. The trigger, usually post-infection, typically in a kid. Presentation, remember the tetrad: palpable purpura, abdominal pain, arthritis, and renal issues. The key sign to spot, that rash on the buttocks and extensor surfaces. How do we manage it? Supportive care, analgesia, and keep a close eye on blood pressure and urine. And finally, the prognosis, excellent, but don't forget that about 1/3 of them might relapse. So, I'll leave you with this to think about. We know the biggest risk is long-term kidney damage, and we know 1/3 of these patients might relapse. So how does that knowledge really shape your long-term monitoring strategy and the way you educate your patients? Thanks for joining this explainer.